Happy morning, dear friends. I'm Dr. Vijay Shankar. I'll give you some insight into the ocular hypertensive treatment study. Coming to the ocular hypertension treatment study, no financial disclosures. Now, we have many patients walking like this into our clinics. A 57-year-old lady with a family history of glaucoma, deep anterior chamber and open angles, and intraocular pressures of 28 and 27 presented to us. Her discs were healthy, her visual fields were normal, and her OCT was within normal limits. Now, do we treat this patient or not? Treatment, her CCT was 620 and 633. Her OHTS fire conversion risk was in untreated cases was 2.8 and treated was 1.7, and treatment was not required in this case. Now, coming to another case scenario, a 57-year-old lady again with no family history of glaucoma, deep anterior chamber and open angles, intraocular pressures of 25 and 24. Her discs were healthy, her visual fields were normal, and her OCT was within normal limits. And do we treat this patient? Her CCT was 480 and 470. Her OHTS 5-year conversion risk was in untreated cases was 44.4 and treated was 26.7. And we had to treat her with latanoprost, and her pressures dropped to 15 and 16 millimeter per mercury. Now, in ocular hypertension, elevated intraocular pressure is a leading risk factor for the development of open-angle glaucoma, and it is the only modifiable risk factor for the development of glaucoma, and patients can lose a substantial proportion of their nerve fiber layer before open-angle glaucoma is detected by standard clinical tests. Now, does treatment of ocular hypertension prevent open-angle glaucoma? Now, there were conflicting views. Some said yes, some said no. So they went in for the ocular hypertension treatment study. Now, this ocular hypertension treatment study is one of the best designed random controlled trials. And the primary aim was to determine the safety and efficacy of topical ocular hypertensive medication in delaying or preventing the onset of open-angle glaucoma in individuals with intraocular pressure. Here the patients were divided into two groups. One was the medication group, another was the observation group. Medicine was started for some patients and they were observed for the results. The secondary aim was to identify the baseline demographic and clinical factors that prevent which of the patients with OHT develop open-angle glaucoma. Now, this study was started on 28th February 1994, and here the patients chosen are between 40 and 80 years of age, and these patients had intraocular pressures of 24 to 32 in one eye and 21 to 30 in the other eye on 2 consecutive visits, with normal visual fields and healthy discs. And these patients were divided into two groups. The number of patients chosen were 1,636 patients, of which 818 patients were medicated and 819 were observed, and after randomization. Now, in case, and the aim of medication was to reduce the pressure by 20% or less than 24 millimeter of mercury. In case the target pressure was not reached, the clinician was free to adjust the medication the way he wanted to till the target pressure was reached. And the glaucoma endpoint was pronounced by the appearance of the reproducible abnormality, which was 3 consecutive visual fields and 2 consecutive sets of disc photographs which showed abnormalities. Now, coming to the results of OHTS, the intraocular pressures were found to be higher in the observation than in the medication group. The cumulative probability of developing glaucoma was much higher in the observation than compared to the medication groups, as you see here. And the first optic disc endpoint was reached faster in the observation than in the medication group, as well as the visual field test. The visual fields showed changes in the observation earlier than compared to the medication group. Now, the various risk factors which can predispose to the open-angle glaucoma include age. Advanced age was supposed to be a very important factor. Patients with African American origin were prone to develop open-angle glaucoma. The other was sex. Males were found to be more affected. Higher intraocular pressure was an important factor. decreased corneal thickness is a very important factor. That increased horizontal and vertical cup disc ratios predisposed to the problem. Now, in OHTS, it was found that increased intraocular pressure and decreased corneal thickness was a very important risk factor in development of open-angle glaucoma. Now, coming to the summary of OHTS, medication reduced 20% of reduction in intraocular pressure. Medication reduced the incidence of open-angle glaucoma in OHT participants by more than 50% at 5 years. That is from 9.5% in the observation group to 4.4% in the medication group, and there was little evidence of safety concern. Now, this OHTS phase 1 went on for 7.5 years, after which they moved on to the next part, OHTS 2. Now, what was the rationale of OHTS 2? OHTS 1 provided the proof of concept. Medication reduces the incidence of open-angle glaucoma. OHTS 1 but does not indicate when the medication should be started, and it does not indicate whether all patients should receive medication, and is there any penalty for delayed medication in OHT. Just like the famous Indian film Bahubali, we had a part 1 and part 2 conclusion. Now the part 1 is over, we are coming to part 2 now. Now, in OHTS part 2, which began on January 6, 2002, the patients were divided into 2 groups, an early medication and a late medication group. Now, the early medication group were the ones who were already continuing their medication of 7.5 years, and the late medication was the patients who were observed, they were started on anti-glaucoma medication. Now, and this creates the early and delayed treatment group as well as early treatment group, and the incidence of glaucoma was compared after 13 years. Now, the intraocular pressure was found to be lowered. The intraocular pressure was lowered after 84 months in the observation group using the following anti-glaucoma medication. So different medicines were used to lower the intraocular pressure, and the cumulative incidence of glaucoma was found to be higher in the observation than in the medication group, though it was very small. Now, the median time to develop open-angle glaucoma in the observation group was 6 years, and the medication group was 8.7 years. Now, in OHTS phase 1, the incidence of glaucoma is nearly 60% lower in the medication group, while in OHTS 2, there was not much difference between the observation as well as medication group. Now, the burden of the disease to study end. It was noticed that as far as it was noticed in 0, it was studied in 0, 1 and 2 eyes. As far as 2 eyes go, in the observation group it was 6% and it was 4% in the medication group. And with the visual field changes and optic disc changes, it was 1% in the observation as well as 1% in the medication group. Now, coming back to the risk factors, as I mentioned before, age, advanced age is a very important risk factor. Increased intraocular pressure, increased central corneal thickness, decreased central corneal thickness, increased pattern standard deviation, and increased vertical cup disc ratio. Now, the cumulative 1300 incidence of open glaucoma, as we see here in the various groups, varied according to the various lowest, middle, and high risk groups. It was noticed that in the observation group it was 8% in the lower risk group, and the medication was 7%, not much of a difference. While there was not a difference between the observation and medication group in the highest risk. It was 40% and 28%. Now, patients who developed open-angle glaucoma had a worse pattern standard deviation at entry and worsened over time, and patients who did not develop glaucoma did not change. Now, coming to the safety, no safety differences between randomization groups, the mortality, adverse effects, and glaucoma symptom scale. Now, how to incorporate information from OHTS into clinical practice? Most of the OHT patients are at low risk. Most low risk patients can be followed without any medication. Delayed treatment for 7.5 years resulted only in a small absolute increase in PAOG in low risk patients, and starting treatment of PAOG and diagnosis had no major negative effect on prognosis for over 5 years. Now, the high-risk patients will benefit from frequent examinations and early treatment, taking into consideration the patient age, life expectancy, health status, and personal preference. Some clinicians may elect to follow all OHT patients without treatment, and this requires timely visits, appropriate tests, interpretation, and very important to remember is risk changes over time. Now, delaying treatment increased cumulative incidence of glaucoma at 13 years, more eyes with structural functional damage, more participants with bilateral disease, shorter time to develop open angle glaucoma, as I mentioned before. Waiting, however, waiting does not have a large effect on the mean deviation pattern standard deviation within 5 years of developing glaucoma. Now, coming to the limitations, the study was 20% reduction of intraocular pressure, was 20% reduction, may not be sufficient. No measure of medication adherence, convenient sample, not population-based epidemiological study, participants healthy and squeaky clean, and also there was high threshold for diagnosing POAG. Now, coming to the summary of the study, early medical treatment reduces the cumulative incidence of open angle glaucoma. The absolute effect is greatest in high-risk individuals. There is little absolute benefit of early treatment in low-risk individuals. There are safe and effective treatment options for most ocular hypertensive patients. The risk of developing glaucoma continues over at least a 15-year follow-up. African Americans, as I mentioned, develop open angle glaucoma at a higher rate despite of similar treatment and similar levels of intraocular pressure. Higher incidence is related to the baseline risk factors, and individualized assessment of risk is useful to both patients and us. Now, using the OHTS EGPS prediction model for developing glaucoma, for the development of glaucoma, we have the calculator here, which will tell us which of the OHTS patients is likely to develop open angle glaucoma. It's available on the web free of charge. Now, the impact of OHTS was done by the American Glaucoma Survey, where the doctors were asked a few questions. The more important questions asked were the measurement of central corneal thickness, and 98% of doctors said yes, it's extremely important. Will you treat ocular hypertension? 78% said yes, and has the clinical practice been significantly impacted? 95% said yes. So OHT is so important basically. Now, coming to clinically useful points in OHTS, measure CCT in all patients, central corneal thickness. 90% of OHT did not convert in 5 years. Majority conversions based on ONS changes. Conversion to open angle glaucoma does not equal the reduced quality of vision. Should we wait for evidence of progression and treat the patient based on risk factors? Thank you for patient hearing.